Okay, welcome everyone. My name's Kirsty King. I'm a practice development lead for the Medway Safeguarding Children's Partnership. And as part of our Children's Safety Week webinars, I'm here to talk to you about the impact specifically of domestic abuse and parental vulnerabilities on the early years. I've got slides. They will be made available to you after the session. There will be time at the end to ask questions. If you do need to interject as I'm going through, please do. Sally, my colleague's on the call. If I don't see them, Sally, please do give me a shout because I'm trying to work off of different screens to see my notes. Thank you.
I will do.
Thanks, Sally. Okay. So the identified vulnerabilities and risk factors on the slide there are based on long-standing research evidence, which tells us that if these are present within the family and there are no corresponding protective factors, then a high percentage of the children experience these will potentially have poor life outcomes, some of which we're going to look at today, specifically for the younger children. But in older children might include such things as, youth offending behaviour, mental ill health, repeated abuse and neglect patterns as they become older, experience relationships and become parents themselves. So it's important we have knowledge of the potential risks and the protective factors in a family, and to remember that these are only predictive indicators. We're not condemning parents who have one or more of these factors. We are highlighting that where these factors exist, additional support is needed and wider understanding of the context of the vulnerability and the family is needed. Many parents with mental health problems are able to give their children safe and loving care without their children being negatively affected in any way. But sometimes parents with mental health problems need support from family members, friends, neighbours, and us guys as professionals to help them care and meet the needs of their children. Many parents with mental health problems are able to manage their condition, minimising impact on children. And this is particularly if they are able to access appropriate support. And of course, sometimes it does affect their ability to cope with family life. Parental mental health problems might affect children differently according to the severity and type of mental health condition, the child's age, their stage of development, and the child themselves. So that's why we need to be aware of the family, their contact, and the context. Many parents and carers who drink alcohol or use drugs do so in moderation, and it doesn't necessarily present an increased risk of harm to their children. However, parents and carers who have a substance use problem can have chaotic, unpredictable lifestyles and may struggle to recognise and meet their children's needs. And of course, this may result in their children being at risk of harm. Now, we're using the term parental substance use problems to talk about parents and carers who have long-term problematic use of drugs and or alcohol. So this might include parents and carers who consume harmful amounts of alcohol. For example, if their drinking is leading to alcohol-related health problems or accidents, they may be dependent on alcohol, they use drugs regularly and excessively, and perhaps are dependent on drugs. Also includes parents who aren't able to supervise children appropriately because of their substance misuse. Of course, when we talk about domestic abuse always has an impact on children. Being exposed to domestic abuse in childhood is child abuse. We know that. It's in working together. It's in law that children are victims in their own rights when they experience domestic abuse in their home. And they may be through experiencing it directly and indirectly, i.e. seeing the maltreatment of others. And just raising the neurodiversity in parents, we need to be we need to be aware of as well. And in the old school, they used to talk about toxic trio of mental health, substance misuse, and domestic abuse. But actually, that then negates all these other vulnerabilities that we identify. So we don't use that terminology anymore, although you'll still see it being used nationally. So we know neurodivergent individuals can be at greater risk of being victims of domestic abuse, and we know that there are barriers to seeking support because responses are not always sensitive to the needs of individuals. Of course, this is also true of parents who have mental health difficulties and substance misuse issues. And while neurodivergency doesn't cause domestic abuse is known to cause or exacerbate mental health and substance misuse as well. And while we're not specifically talking about the parents, we're talking about the impact on children specifically today. Obviously, if I had longer, we'd dive into that as well. We have at the moment a challenge of engagement with men, and that thread is coming through many of our reviews in terms of not necessarily considering the vulnerabilities of the men in the family, or the impact of the men in the family, or the risks of the men in the family, be that the partners, the fathers, step parents, other men in the family as well. And we just need to be aware that when we are working with neurodiverse people, that there are challenges to working with them, but there are also examples of what works well. So, tailored support, small groups, skilled facilitators who are experienced with working with neurodiversities, working in groups where there are others with neurodiversities, and just for all of those individuals experiencing domestic abuse who have who are also neurodivergent, it's having clear, accessible information, having alternative communication methods, and really supporting empowerment and independence. So, chicken and egg. The term dual diagnosis we hear sort of bandied around a lot. Usually it's around someone having two diagnoses, formal mental health diagnoses to formal health diagnoses. But actually we interchange it as professionals. We use dual diagnosis and co-occurring disorders. And this covers a broad spectrum of mental health, substance misuse problems that an individual might experience at the same time. And the nature of the relationship between those two is complex. So it could be there's a primary psychiatric illness precipitating or leading to substance misuse worsening or altering the course of a psychiatric illness, intoxication of substance dependence leading to psychological symptoms, or substance misuse and or withdrawal leading to psychiatric symptoms of illness. Unfortunately, it is difficult to accurately detect a dual diagnosis and co-occurring disorders because substance abuse often masks an underlying mental illness, or vice versa. It's a complex situation where the two are often occur together, and they can exacerbate each other, making it hard to pinpoint a definitive cause and effect. And if parents are facing, several challenges at once, it can be very hard for parents to provide their children with safe and loving care, particularly if they are isolated or they themselves are not getting the support we need, that they need. They need the support to combat their vulnerabilities, to address their trauma, in order for them to then be able to meet the needs of their children. Research has found that there is greater risk to children's safety if parents with mental health problems are also experiencing domestic abuse and substance misuse as well. So it's so important that we identify and we approach all of the vulnerabilities. We don't just treat them in isolation, because they are often linked. And whilst we don't necessarily know cause and effect, again, we know domestic abuse can exacerbate all of these issues. Carrying on with sort of the idea of co-occurring issues, some parents experience their vulnerabilities alongside other challenges that perhaps if they didn't have the vulnerabilities wouldn't have so much impact on them. And these are just obviously some challenges listed here, which may be caused or affected by their vulnerabilities. And research has found sort of nationally, child protection plans often did not adequately address the social issues, such as housing in particular, and intergenerational trauma. We often say, okay, and what is the parents' experiences of being parented, of being young people, of being in relationships? What has impacted the situation that they are in now? We're always asking, what happened to the parents as well. And that is often missed or perhaps not developed or understood. Also, the research was finding that boys who were experiencing domestic abuse were frequently left unsupported, and this thing contributed to the cycles of harm repeating themselves. We often saw in the research as well as our approach to women and men. I mentioned earlier that there's a thread through our reviews currently about how we're engaging with men or we're not engaging in men. But they also found there's a sort of a different approach to an attitude to working with men and women as well. And women are shown relatively more compassion when they were making what they were quoted as being unhealthy relationship choices. Domestic abuse is not a choice, whereas men were viewed as the rational actors in their lives, and they were exercising their power, and this didn't acknowledge trauma that they'd experienced, their own mental health issues, own substance abuse issues. And framing our approach to men and women like that then does impact the effectiveness of our interventions with those people. So the widely held assumption that babies and very young children are unaware of and consequently can be shielded from the impact of domestic abuse has now been debunked. Okay, we know children hear, we know children see, we know children feel. So fundamental to the health and development of an infant is a caring adult who can meet their needs for love and affection, adequate food, and a safe environment. Anything, so any of the vulnerabilities, any of the social issues, anything that is undermining a child's needs being met needs to be addressed. And this might be through, compensatory experiences, through protective factors, and potentially then possibly interventions by services. So I'm going to go through some examples of impact specifically for domestic abuse on children under 5 years, sort of from pregnancy upwards. But for your own reading, there is a publication. It's called Caring for Children Who Have Experienced Domestic Abuse, a guide. It's from Quorum. It's a guide for supporting foster carers, adopters and kinship carers. But actually, there's a lot of information in there that would help support all practitioners working with children who have experienced domestic abuse. But they do publish, and obviously you have to pay for their publications, but they do publish 3 chapters. And chapter 3 in that publication explores the impact of domestic abuse on the children under 5. So it's very topical for us, and the link's there so you can go and have a look at it. But I'm going to explore quite a lot of what they cover here. So it's a bit of background reading for you. So as I said, some of this information has come from that publication. Some of it's come from our guidance that we have in Kent and Medway as well. And it's really important that when we look at domestic abuse, we look at the impact on children. There will always be an impact on children where there has been domestic abuse in the family. So if children present as functioning, and I'll say this again, they present as functioning, that does not mean that they have grown resilience because they have been traumatized. It may mean that the trauma they experience will manifest in different ways that we just don't know yet. And we know 1 in 5 children in the UK experience domestic abuse. That's a lot of our children. We also know here in in the South East, we do have high rates of domestic abuse, and one of the busiest MARACs, which is the multi-agency risk assessment conference that helps to support high risk victims of domestic abuse. So it's a lot of our business in Medway is associated with current and non-recent domestic abuse and the ongoing impact of that. Okay, we're not just talking about impact of an incident, we're talking about ongoing long-term impacts of living with domestic abuse. So pregnancy can trigger the start of physical violence and abuse within relationships, or it can increase the severity and frequency in those relationships where there is already domestic abuse. So around 30% of domestic abuse begins during pregnancy, and around, depending on what statistics you look at, 40 to 60% of women experience domestic abuse. 40 to 60% of women experiencing domestic abuse are then also abused during pregnancy. And this is a high risk time. So domestic abuse causes the victim stress. So widely known as the stress hormone is cortisol. So usually you have the placenta, and that protects the unborn baby from mother's cortisol, because we all have cortisol. It's a naturally occurring stress hormone that we have. And I'm not going to go into the science of it, but when the mother is very stressed, then the placenta works less well at protecting the baby from mum's cortisol. So when the cortisol is able to, cross the placenta to the baby, we know it's been shown to be linked adversely to the development of the baby's amygdala, and which is the area of the brain involved in emotional and social development in childhood. The unborn babies that are exposed to high levels of cortisol over the period of the pregnancy are more likely to develop behavioural problems and have lower cognitive development by the time that they hit their 18-month milestones. So, already we're thinking this long-term impact. And that the abuse might have ceased, the mother may have left the relationship, but because the baby has been exposed to that during the pregnancy, there is a potential that the damage has been done there. So then we need to make sure that we are rectifying that, and we are aware of the implications that may have had if they've experienced domestic abuse in utero. Research shows us there's an association between prenatal exposure to domestic abuse and birth outcomes, including low birth weights, and then these children having stress response alterations, temperamental difficulties, having internalising behaviours, being sad, being inhibited, or they may have externalising behaviours, being operational, aggressive, rule-breaking, impulsive behaviours. And this is from, as soon as they are walking around and able to start expressing themselves, you will start seeing these behaviours. It's not in school age children, it's from day one. Also, obviously in pregnancy, we know that assaults can cause miscarriage, stillborn, births, may result in premature labour, and of course this is underreported, and we're not always going to explore the reasons for early miscarriages, because sometimes things happen. There are many causes as to why these things happen, and if it is not disclosed that there is domestic abuse and there has been an assault and there's no bruises we can identify, the risk of this being underreported is there. Drugs and alcohol can be used obviously to self-medicate or as a controlling mechanism within the abuse. If there's pre-existing substance misuse issues as well prior to the pregnancy, this drug use may harm the developing baby in multiple ways, and that might depend on stage of pregnancy. So very early on in pregnancy, the baby is susceptible to structural damage, whereas drugs taken later in the pregnancy can also affect growth and obviously cause neonatal addiction as well. Impact of drinking in pregnancy is related to the amount, obviously, and the pattern of alcohol consumed by the mother. But we know it's increased with increased rates of miscarriage, can cause fetal alcohol syndrome disorder, FASD. Again, underdiagnosed. There are characteristics you can identify when a baby's born, but that's not necessarily a foolproof way of identifying it. And this is where, if mother has been drinking in pregnancy, obviously the alcohol can get through the placenta and it's damaging cells in the baby's brain, their spinal cord, their parts of the body. And as I say, this can cause, babies that are born may be left with lifelong problems, including difficulties in impulse control, as well as behaviour and learning difficulties as well. Potentially, the young unborn could be at risk of poor development due to the difficulties in mum being able to attend support appointments, antenatal appointments. And this could be because they are being controlled and coerced by a perpetrator, so that they are restricting contact with services. Obviously, if they are accessing services, we routinely inquire about relationships and the potential for domestic abuse. So the more contact a woman has with services, the more opportunities there are that the domestic abuse is going to be identified. Or domestic abuse has left mum with such low self-esteem and depression that she's, failing to look after her own and the unborn child's, physical needs, and that does include attending clinics. So if we have got a regular attendance during that antenatal period at support sessions, we need to investigate those, because irregular attendance has been shown to be associated with other pregnancy complications such as, preeclampsia, eclampsia, the high blood pressure disorders, and with anemia as well. And it's linked to adverse birth outcomes, and preterm birth, low birth weight, and stillbirths. So, as I said, a lack of engagement or non-attendance, whatever we want to call it, needs to be analysed for what's going on. What do we know is going on in the family? Also shown that domestic abuse has shown mums to have a lower attachment to their unborn when compared to non-abused women. And this could be a protective response because, the victim wants to disassociate themselves from the child, so the child can't be used against them or can't be harmed in order to harm them. And the baby may be as a result of rape or the perpetrator's controlling access to birth control. And that may impact the attachment that mum feels with the baby. So in some cases, obviously, the effects, and we will talk about, compensatory effects on children later. The effects of domestic abuse on mum and baby can be mitigated, but only where there are these protective factors, including the antenatal care, where we do talk about relationships and a network of safe and supportive people. And that might be us in our roles as professionals, or it might be the wider family that we need to understand as well. So very young children exposed to domestic abuse may have been the unintended victims of both physical and emotional harm. So being caught in the crossfire, an injury. We know even very young children try and get in between parents where there is physical abuse. We know that very young children are used within abuse. Perpetrators groom the children into their behaviours as well, and so therefore they are being abused in that way. Obviously they're particularly vulnerable to suffering injury, illness and neglect, because they're unable to avoid this danger or defend themselves. These are very young children, and if they're not engaging in sort of preschool settings, then they're not being seen by professionals either. So as I said, being caught in the crossfire, being held in mum's arms during a physical assault. We have cases where they've said, oh, we thought if we held the baby, and this is not to blame the victims at all, but we thought, holding the baby would prevent them from trying to get to me, but they still try and get to me because it's like they can't see the baby. Or they might be deliberately targeted, obviously, in order to punish the victim. Domestic abuse is driven by control and the need to dominate. So very young children are, they're in danger at that time where there is this grown adult trying to control and dominate the lives of the victim and the lives of the children as well. Arrival of a baby can, create intense jealousy from the perpetrator. New mothers can be, acutely aware that the time that they are spending breastfeeding could be a trigger for the perpetrator, or renew the abuse, because their focus is not on the perpetrator, and they're not prioritising the perpetrator's need at that time. So therefore that may then lead the mothers to prioritise the perpetrator's needs at expense of the baby, because it's a way of trying to manage the abuse, which we know can't be managed because perpetrators are in control. So yeah, as a result, you might get irregular feeds, you might get less attention and affection when the perpetrator is present for the baby. Regular sleep patterns for babies. We talk about routines, if babies know what routines are, and that may be really hard to establish where there is domestic abuse in the home. And research shows us that babies who are living with domestic abuse are subject to poor sleeping habits and excessive screaming as well. And we think about babies not being necessarily able to know what's going on. And sometimes we'll read reports and they go, oh, I didn't get the voice of the child because they're a baby. But there's multiple examples of children showing you in their behaviour that something distressing is happening to us. The National Child Trauma Stress Network published a paper. One of the examples in there was an 11-month-old that was present when mum was being attacked by a boyfriend, and she kept waking up at night screaming. And that was, trying to show us what was happening for her. Something was disturbing that, and that's what we need to identify what that is. Now, we know babies cry, but, and some babies can't be easily soothed, and this also could be something that the perpetrator of domestic abuse sort of hones in on. They become extremely frustrated, they can't control that. They may attempt to stop the crying, control the behaviour, and that might be through shaking or violence as well. Young children might be harmed because if the domestic abuse is affecting mother's mental health and leaving her in a state of apathy, indifference, with impaired concentration and suppressed emotions, then this could, the consequences of not being present and her lack of attention may result perhaps in accidental injuries of the children. So babies being left in baths, for example, children sent out to play unsupervised. So children under the age of 5 living with domestic abuse and violence, they're at increased risk of having to attend medical services because of burn injuries, for example. So that age group, the children under 5, accounts for around 70% of children who attend UK medical services. And the most common risk factor are prior injury, parental mental health problems, and domestic abuse. So we really need to think what the impact of these parental vulnerabilities has on the supervision and the care of these children. Infancy is potentially, the most vulnerable period in childhood because it's a time, and not, all parts of childhood can be vulnerable, obviously, but it's the time of the greatest postnatal brain development. So between sort of the ages of 6 to 18 months, the orbitofrontal cortex in the brain matures, and that area of the brain is involved in cognitive processes of decision making. It's associated with the social and emotional interactions. It's part of attachment development. And when the predominant early experiences of a child are fear and are stress, then they can have a significant and enduring effect on how the brain is developing. So we know a lot more about the brain than we ever had before, and we can see in brain development an association between witnessing physical familial abuse and these changes in infant brains. Obviously, we also know about cortisol. So these children, they're under extreme stress, they are experiencing trauma. They will also be secreting and processing of cortisol. And, this hormone, we know, disrupts neural development, and that's going to result in emotional, social, and cognitive impairment in very young children. The experience of trauma in infancy also increases the brain structures involved in vigilance, and that can result in these children permanently being in a state of arousal, numbing, or avoidance, engaging their sort of fight or flight responses at a very young age. And to stay in those states is very damaging to our health. So as I've said, obviously first years, very important for cognitive language development. There was a longitudinal study of 5-year-olds, and it was England and Wales. And they found, again, exposure to domestic abuse associated with children's delayed intellectual development. More research in sort of along the same lines showed that domestic abuse during the preschool years, then negatively affected children's cognitive skills, and obviously that affects their ability to learn, then that affects their life outcomes as well. And these things can come from parents being not necessarily preoccupied, it's probably the wrong word. They're victims. They are being impacted by the domestic abuse themselves, or the perpetrators are not parenting either, because they are preoccupied with their actual own needs and their own emotions, and therefore these parents are either unable to, victim, or unwilling to, perpetrator, notice their children's or wishes, or to respond to them appropriately. So for victims as well, the feelings of exhaustion, being a victim constantly, having a white noise of domestic abuse, thinking about where the next incident is going to be, what's the next trigger, how can I manage this, that's exhausting. This with depression, undermined self-confidence, low self-esteem, low self-worth, and all those are factors that we associate with domestic abuse, and the other vulnerabilities we've mentioned may just result in the parents not having capacity to engage, not having the capacity to stimulate their children. So that might then mean that there are significant delays in their language and general understanding, and that when these children do eventually engage in school settings, be it nursery or from school age, they may be behind their peers in that development as well. We also have seen that growing up in these violent and chaotic households is associated with children who show not a lot of interest in their environment. They're not out there exploring. They're unsure of their parents' behaviour, and they fear triggering an abusive episode or a violent reaction. And their courage to be able to explore has really inhibited their natural inquisitiveness, if you like. They don't want to go out into the world around them because they're scared of what it is. So they don't explore, and we know that is a really necessary element to how we as humans develop autonomy, and our independence as well. So if children are able to access preschool facilities, so nurseries, playgroups, social groups, this can present a compensatory experience, if you like. So it compensates for the lack of stimulation at home, and it also gives them an opportunity to interact, obviously, with other children, other adults. But obviously, where there is domestic abuse in the home, they may not be able to regularly, on a regular basis, access the preschool setting. They may be being controlled, being prevented from enrolling their children in these groups. They may be prevented from leaving the house even, or even, the abused parent is experiencing poor mental health, or they are trying to avoid detection of the signs of abuse. So, bruising, they don't want to go out in public. People are going to ask questions, especially professionals. So they're just avoiding anyone that might be able to identify what's going on, because they need to be able to manage that themselves. They may just not have the ability that day to get up and get their children ready and on time. And, for a number of reasons that we associate with domestic abuse, but also there are other vulnerabilities as well. They may be feeling emotionally unavailable, unresponsive to their children. And where a parent is emotionally unresponsive to you, that creates fear and, a whole amount of other complex unresolved emotions in children. And we know that this lack of emotional availability will impact negatively on their attachment behaviours that we can identify with parents, we can identify with family, anyone that comes across the child's path, really. So the process of attachment could be interrupted at this very early stage because of the parent being unavailable, but also even the perpetrating parent being absent from the home is going to interrupt that attachment. They're arrested, or they leave, or the victim, the abused parent, is able to leave with the child as well. That's going to disrupt attachments as well. They may have unplanned moves, separation, obviously, and that their loss of a parent figure, even with the problems that being an abusive or a victim of abuse and being a parent presents. So this leaves kids with, extreme anxiety, and they might express that through a number of ways. This might include bedwetting, sleep disturbances, rocking, head banging, hair pulling, hair eating. We see in very young children. So again, they might not be verbal, but they are showing you what they are going through. They have a voice that we need to be identifying. Emotional development is obviously going to be impeded, and this might not be obvious at the time. Again, it's about they may not be able to then regulate their emotion and develop those sort of emotion regulations as normally as others that haven't been in those households. If the parents can't provide safe environments, then that's obviously going to impact the child in physical ways, emotional ways, mental health, brain development, socio-emotional skills. So in the early years, an infant's emotions and behaviours, we also know generally mirror the moods and actions of those who are caring for them. So if you have a victim, if you have a perpetrator, these little sponges of children are going to suck up everything that they see in terms of how a parent is behaving, be it as a perpetrator or a victim, and also the emotions and moods that victim and perpetrator are going to be in. And, these children are then not experiencing love and affection, so they feel unloved, they feel unlovable, they feel unwanted. And then you might see children who become, touch hungry. They show no discrimination between their parent and strangers. So they may be unduly clingy and fearful. And, if you're going into homes, you're working with children, you can identify these children who are clingy. And it's not, some children have very secure attachments, and because they have a secure attachment, they will explore their environment and they will go up and talk to strangers because they know they have the safety of the parent behind them. And that's fine, but also we need to be thinking if they are overly clingy to people that are strangers, why is that? Are we also seeing, what attachment are we then seeing with the parents? So, it's not the definitive, it's what else is happening here? Is there positive? Is there negative attachments there as well? If they are seeing, hearing, watching arguments, violence, they're going to be sad, angry, fearful, confused, grieving the parent that they want, lonely. And they can't verbalize their emotions. So we know that children who can't verbalize their emotions act out in other ways, crying, resisting comfort, becoming despondent to others. But we also know that children living with domestic abuse can suffer symptoms of post-traumatic stress disorder. And we also know that those children who have perhaps not experienced domestic abuse until into childhood will potentially regress to earlier childhood behaviours, such as, going back to inconsolable crying, loss of toilet training, asking for bottles when they've moved on to cups. There's also a lot of research that identifies very young children mimicking the behaviours of the perpetrators in the home as well, which I'll go on to on this slide. So if domestic abuse has led to the poor mental health or substance misuse, the abused parent may be lacking the capacity to care for their own or the child's appearance, their needs. Child may be neglected, basic hygiene is ignored, they may be unwashed, they're dressed inadequately, they don't have adequate clothes or clean clothes. And these children, you see a lot of, 4-year-olds being quite independent, being able to dress themselves and things like that. But, they're not at a point where they can look after themselves at all. And then, how a child is presented, how they look, how they smell, obviously then impacts on how others interact with them as well. So if they are in a social setting and they are the unwashed, smelly kid, what impact is that going to have on them being able to form relationships with peers, or other parents wanting their children to engage with that child as well. Children can develop negative and distorted beliefs about themselves as well. They don't have the confidence, they don't in themselves, they don't have confidence in adults to be able to protect them. We might get children who have a belief that they are to blame for the abuse as well. They can link things that aren't linked together. So if they have been told off by one parent because they haven't put their toys away, for example, and then later that day, or subsequently, not subsequently, later that day there is domestic abuse, there is an incident of violence, they may associate that behaviour of I didn't put my toys away, I got told off, with that incident as well. And obviously they won't understand that they are not to blame for that, and that they don't understand what domestic abuse is about power and control, not necessarily a trigger because of something that's happened. I've already spoke about parental attachment to baby as well. But in terms of play, so children exposed to domestic abuse, more problems in playing, interacting with their siblings, with other children. They're more likely to experience or display rather anger, peer aggression, and behaving in challenging ways because of the trauma they've experienced as well. And that may be supported by, parents not willing to engage in play or socialise with other parents because of the vulnerabilities, be it domestic abuse, mental health, neurodiversity, or substance misuse that they have as well. And in terms of mirroring the behaviour that I mentioned, we see this in very, very young children. So in one study of victims of domestic abuse, they were sharing about their children's aggressions, and they were 14-month-olds. They were saying that they said they beat on their sister, and they're hitting and they're biting, and they're 14 months old. Or there's accounts of mum saying, this child has told me when I get bigger, I'm going to hit you like my dad. These children are they learn. All children learn by mimicking, by interactions, and if these interactions are violent and abusive, they will still mirror them because they don't know that they are abusive. So when we are working with children, and it doesn't matter what service you work for, we need to be looking at what the impact of these vulnerabilities that parents have and that exist on children, and determining it. And again, these are the questions for us to ask ourselves when we're working with families. They're not the be all and end all. Some behaviours may not be presenting themselves. Sometimes the impact is not presenting itself to you in your role. It might be presented or identified by someone in another role. Trauma manifests in many different ways, but we have to determine, in order to be able to support, what is the potential impact of the vulnerability on parenting ability, the child's development. So these are some examples of questions to be considered in your sort of assessments, whatever assessment it is you're doing with families. And these can be found in the Kent and Medway safeguarding procedures that we have. But it's thinking about child's role in the family. What are they doing? Is it inappropriate? We see under fives being caregivers and being emotional supports for parents. This is inappropriate for their age group. Well, for most age groups. So, what is their role in the family? I spoke about attachment. Is there secure attachment? Is there positive evidence that there is secure attachment? What is it in the behaviours of the children that we can see that might be undermining the attachment? What do we know about the family that could have this impact? As I've said, we can talk about all the research that says this is a potential impact. So, is this having an impact on those relationships as well? What's happening in the home in terms of routines, in terms of boundaries, in terms of our meals at the right-ish time, are they being provided, and are they adequate? The graded care profile will help you here in structuring that thinking, because we are potentially going along the lines of what need of the child is being neglected as an impact of there being these other vulnerabilities. Is there any vulnerabilities that impact attending preschool, health appointments? And this could be any of those vulnerabilities that we spoke on, the first slide. Like, are any of these getting in the way of children being able to access the universal services that we offer? And it might be as simple as, parents have got so many other appointments because of vulnerabilities, and they're engaging in mental health, or they're engaging in drug and alcohol substance misuse services, or they're on a parenting program, and that fills up their diaries. And sometimes it's quite hard to manage a busy diary, and then just a routine appointment comes in for the dentist for immunizations. Which one's going to give first, and what happens when they clash, and how are we supporting parents to communicate that need as well? Do the parents recognise the need of safety for the children? If they are being left unsupervised, or a parent says, "Oh well, we put them in the other room when something happens." I try and protect her. I pop them in the garden. I was like, well, is that age appropriate? Is the garden secure? What else is out there? Are they liable to fall? Is there water? Is there, but something that they can burn themselves on? Because, like I said, 70% of children accessing this medical help is as a result of being injured in the under 5 age group. So is there repeated hospitalisation, or repeated attendance for injury as a result of not being supervised appropriately? Are they blaming the child? Are they scapegoating the child and blaming the child there? Are the children actually, where are they when the abuse happens? Where are they when perhaps there is a relapse on sobriety? What happens with the children there? Are there other people in the family that can step in, support, and meet the needs of those children as well? And we really need to think about, when we're responding to people who have these vulnerabilities, think about the family in their context. Is there any impact on how we are able to work with them in relation to culture, ethnicity, religion, or any factor within the family that will either undermine what we want to put in, that we need to change our approach? And obviously, perhaps in some cultures domestic abuse is more prevalent. That does not mean it is right. It's still against the law. Children are being, the aspects of the abuse is against the law. Children are being abused if they identify as domestic abuse, regardless of, what culture they come from. But we need to be recording attitudes and beliefs, and, what the support network is inferring to them, and the roles of women and men in their culture, in their community as well, so that we can understand, one size approach will not ever fit all. And part of those holistic assessments, I've already mentioned about things like, what are the vulnerabilities of the parents, the thoughts and feelings of the children, even when they are non-verbal. We find a way to record how that child is trying to communicate their feelings and their experiences. We go back to what is life like? What is the life experiences of these children? The abilities of the parents. And like I said, we're not condemning any parent that has these vulnerabilities. They will be able to, they may be able to parent without support. They may need extra support, but we also need to think about, are we saying that the care these children are receiving is good enough for the children, or are we saying this is the best the parent can do? Because if the best the parent can do does not meet what the child needs, then that is still not acceptable, and we should not be accepting we need to be able to make sure we are supporting the parents to meet the needs of the children, not to accept the level of care the parent is able to give at that moment in time if it is under what the children needs. And talking to other professionals, it's so important that we get opinions from the other professionals, we get accounts from the other professionals. You know, if you've got a 10-minute appointment with a child, you're not necessarily going to see all the behaviours that they're going to exhibit in perhaps a preschool setting, or that the health visitor is seeing on their developmental checks, for example. So, you know, talk to each other as part of your assessments. And I've been speaking about protective factors. I just want to reiterate, children cannot and never can be responsible for being a protective support or factor to their parent or carer in reducing the risk, okay? If we believe children are protective factors, then we are increasing the risk of harm to that child, okay? We erroneously assume that having a child will make a parent or carer less likely to harm in an actful manner. We know that's not true. It also means that we're perhaps not considering whether there is a risk of harm directly to the child. And it also may discount the impact of parenting stress on the mental ill health there as well. So if we're saying, oh, the protective factor is because they've got a child, well, you know, parenting is stressful. So what is the impact on parenting stress on the vulnerabilities that the adult has themselves as well? And by saying that child is the protective factor, there is a risk of us saying not identifying that. So protective factors are us as professionals. They are wider family. They are wider family, so even the support. It's that the community know what is going on for the family, that there are things like, you know, young carers support in the wider family, that parents have advocacy, that they are supported to engage and speak, and that other challenges have been dealt with. You know, they are protective factors, that the family is receiving all the benefits that they are entitled to, all the housing support they're entitled to, or the legal advice they're entitled to if they're going through court cases, for example. They are protective factors. Children are not protective factors. In terms of supporting children, also giving them an advocate, you know, having them have a trusted adult outside of their parents, giving them age appropriate information, especially when we're talking about sort of mental health problems. You know, studies show that children want to play a role in contributing to the care of their parents. And, you know, even when we're talking about the other vulnerabilities, children want to protect their parents. Children, you know, school-age children want to stay home from school to protect their parent who is being abused, because they see it as their role. So, you know, we don't want to discount that, but we want to have their involved in age appropriate conversations about what is going on for their parents as well, so that can be, you know, built on as they get older as well. And that can help with, you know, the fears that the children may have about what's going on with their parents. Perhaps one is away for a little while because they're receiving treatment, you know, what that means. We're not talking about having adult conversations in front of children. We should not be doing that. We should be having age appropriate conversations about what is going on in the family. And we need to be able to give them an out, you know, so if they can play with peers who have similar vulnerabilities to them, that will help, because they will have peers who then have experienced perhaps the same impact of the parental vulnerabilities on them that they have as well. And this is all part of building those positive and compensatory experiences by, you know, integrating them into a community, and also using the universal services that we have. I mean, for the underage of 5, it is going to be difficult because there's not a lot of specialist services per se for, you know, domestic abuse programs often start around sort of the age of 7. The Domestic Abuse Commissioner is working on that currently, but, you know, we know that is a challenge. But there are all of these, you know, schools, health visiting, school health, our mental health service for our children and young people. You know, these are all services that go from naught plus, you know, so we need to be engaging them as well, because that will add to the positive and compensatory experiences. And what we know about brain development, I've spoken about quite a lot about brain development earlier, the science we know about this now is that the brain is very adaptable. It can actually rewire itself in response to experience. So that means that the damage that is being caused by the abuse, the trauma, is not necessarily permanent, and that with the right support, we can heal. The brain can repair itself, and children, they do not become resilient because they have lived through trauma. The longer a child is traumatized, the worse their outcomes may be. So just because they seemingly function in traumatic environments doesn't mean that they're not impacted. The impact of trauma is known to manifest in many different ways, as I've said before. On this slide here is some examples from the PACES lab that are positive and compensatory experiences. They're different colour coded because one is environmental and one is relationship. So, having unconditional love from a parent is a compensatory experience. Trusted mentor, as I said earlier, that advocate for them. Having a friend, having a best friend, and having that social connection. And obviously for adults, these are for children and adults. So, the people who you are working with who have had these adverse experiences will also benefit from this sort of framework of compensatory experiences as well. But yeah, having boundaries, having routines, having the opportunity to learn, be active and develop their skills and hobbies. Multi-agency working is so important. And I think I just really need to reiterate here that adult services supporting parents need to be included in those meetings where you are discussing the implications of the parents' vulnerabilities on the children, because they will understand the parent vulnerabilities. Okay, we're not adults. If we're working children's services, we perhaps don't have all the information and knowledge that adult services from across the piece, mental health, social care would have, and vice versa. So if children support services from across, from universal through to statutory, they also need to be engaging in the adult services management of adult vulnerabilities as well. We need to be understanding vulnerabilities, diagnoses, the management, the risk of relapse, how it might present, what the implications of that presentation might be, so that we can build joint plans, we can build contingency plans for when things happen. Perhaps parent comes off medication, there's a relapse in alcohol use, there's a new relationship that is abusive, and then we can reassess risk. And it's so important to keep reassessing risk of all of these vulnerabilities. Obviously, if we believe that child is at risk, then the children's services referral procedure, the link's there for you, should be invoked. But also, these families might just need a little bit of early help, and we're all responsible for early help. Or we might just need to do, perhaps we could do the graded care profile with them if we're identifying that there are signs of neglect in the family as well. Oh, so that is the end of my presentation. The final slide there is just for a evaluation. If you could please scan that with your smart device and complete that. That's really helpful for us when we're developing these webinars. As I said, this recording will be available online on our YouTube channel. So YouTube, just search Medway Safeguarding Children's Partnership and it will pop up. And we will be sharing the slides with you as well.